So good afternoon, everyone.
Good afternoon.
I take this opportunity to welcome all of you on behalf of Wockhardt Pharmaceuticals for this very interesting panel discussion on the topic of lab diagnosis of COVID-19. Last 6 months have changed completely our perspective about managing multiple diseases. This has something happened which has really changed the way we are living. It has really changed the way we are doing things what we used to do in the past. But I would also like to say it has really shown how resilient as a country we are and how we have responded very strongly to this challenge which has been posed by COVID-19 and how resiliently we are taking this forward. I think the most important aspect, even more than the management of the disease, is the diagnosis of the disease. Because contact tracing and isolation of the identified person is one of the critical aspects in controlling the disease circulation. And that's why COVID diagnosis plays one of the most important and critical aspects in management of the whole disease. So I would like to now introduce the esteemed faculty members who are today with us. First of all, we are really thankful to Dr.
There's a
Poonam
lot of disturbance in the background.
Session today. Dr. Poonam is director, professor, and head of the Department of Microbiology at GB Pant Hospital. She is an alumni of Lady Hardinge Medical College from 1991 batch. And she has worked as a consultant at separate medical institutions and hospital, Guru Nanak Eye Center, and she has extensive experience in the field of hospital.
Dr. Rishi?
And yes.
There is a lot of disturbance while you're talking.
Coming from my side?
Yes, it is from your side.
I'm actually in a very silent place. I don't know from where it is coming.
Yeah, you can go ahead. I think.
Can we mute everyone else and see?
Yes, yes.
Going forward, we also have Dr. Alpana Razdan. Dr. Alpana is Head Genestering Center for Medical Genetics. We also have Colonel Dr. Panthare, Head of the Department and Senior Consultant Microbiology and Virology, Onquest Laboratories, New Delhi. We also have Professor Colonel Prabal Dev, Director Lab Operations and Chief Histopathologist, SRL Limited, Mumbai. Dr. Raman Sardana, Chairperson and Head Infection Control, Academic Advisory Lab Services, Adjunct Professor, Senior Consultant and Head Microbiology, Apollo Hospital. We have Dr. Sanjay Mehta, Managing Director, iGenetics Diagnostic, Mumbai. Dr. Shalab Malik, National Head Microbiology and Serology at Dr. Lal Path Labs. Shelly Mahajan, Clinical Lead for Genomics at Caring DX Mahajan Imaging. Dr. Sunita Kapoor, Director and Lab Head and Consultant Pathologist at Ray and Scan Clinics Private Limited. Dr. Tina Wadhwa, Senior Consultant Microbiologist at Medanta Medicity, Gurugram. Along with that, we also have Dr. Sanjeev Sharma. Dr. Sanjeev is my colleague at Wockhardt Pharmaceuticals. He's a Senior Vice President there and is heading our R&D and Biotechnology Center and heads a very big lab and diagnostic facility at Aurangabad. And myself, Dr. Rishi Jain, I work as a medical, clinical and regulatory head at Wockhardt Pharmaceuticals for the India and rest of the world business. With this, I would like to request Dr. Poonam. Dr. Poonam will be the key moderator for the event today. So please take this forward and start with the discussion. I will unshare my slides now and I will request you to share.
Yes. Well, good afternoon, everybody. So while I just start sharing my screen, welcome to this discussion and panel discussion on COVID. As you know, COVID has kind of ruled our lives since, as you know, that COVID has been ruling our lives since the last so many months, and that's all what we're talking about. We have with us a very esteemed group of panelists, all of who have an extensive experience not only just in COVID, but also in virology and molecular testing and diagnosis for the last so many years. COVID has only now just come up. So we will start the panel discussion. And to start with, since you all already know about COVID, to recap in brief the history, COVID came up first in 27 December when WHO came to know from China officially, unofficially, well, nobody knows the picture. 7th January, COVID was confirmed by CDC. 13th January, it crossed the borders. It entered India on 30th January. And today, as you all are well aware, we have more than 2.5 million cases of COVID already. So this is where it goes. And India is well on its way to kind of bypass and surpass Russia and US in the near future, as the number of testing is gradually increasing. So coronavirus is basically an envelope protein, single stranded RNA virus. It is rounded in shape, and the diagram is shown below. The main structures out there are COVID virus are that there are 4 types of coronavirus: alpha, beta, gamma, and delta. Alpha and beta are the animals and bats and rodents. And as you all remember, China bat soup and bat something was responsible for the starting of this whole pandemic. And so SARS-CoV-2 is a beta COVID virus, and it has both structural and non-structural proteins. So the structural proteins are as shown in the figure: envelope, membrane, nucleocapsid proteins. The spike proteins are present on the surface of the whole virus, which gives it the name corona. When we come to the genetic structure, going from the 5' to the 3' end, 2/3 of it is taken up by the open reading frames. There are 12 open reading frames, of which open reading frame 1, ORF 1A and 1B, take up 75% of the whole genomic structure. And they have a lot of these, especially the RNA-dependent RNA polymerase and the other non-specific proteins. The remaining 1/3 is taken up by the other spike proteins, E, M, N, and the accessory proteins. So looking at this diagram, it gives you an idea of what are going to be your targets for the testing and what are going to be the targets for vaccine. So currently we're talking only about testing because vaccine is a long way forward. So I would like to request Dr. Sanjay Mehta and ask him that what are the indications of testing, when should you get testing, what is the ICMR testing strategy? So Dr. Sanjay Mehta. Dr. Sanjay? Yeah, Dr. Sanjay, yeah.
Can you hear me?
Yes, we can hear you.
Yeah. Good afternoon to everyone. And the indications for the testing for COVID-19, I've divided into 4 groups. The one which are symptomatic patients, where they come with the symptoms of fever, headache, body ache, chills, rigors, dry cough, fatigue, and some neurological disorders also, like loss of taste, loss of smell, gastrointestinal symptoms like diarrhea. All these things, when it comes, the doubt of COVID comes up. And the 4-day post signs of symptom is an ideal time to check this kind of patients. Then I go to the second group where the asymptomatic patients comes. Asymptomatic patient, those who are in direct touch with the COVID positive patients, and there the best time to do is a 5th day post-COVID contact. The asymptomatic patient, people are also carrying the same risk, and I mean they only spread this disease more than the symptomatic. Then I go to the other group where the pre-operative, like pre-surgical, pre-gynec, like delivery or cesarean section or any surgery, one should check the COVID-19 test to prevent the spread to other guys, the treating people, and the sisters and all like that, the hospital staff. And the 4th category will, nowadays the international travel is started, and it has become mandatory to check the COVID testing for before traveling. So that is, and there also like I'm getting patients from different airlines And there 48 to 72 hours before starting your trip, one is to check the COVID-19. So these are the categories where indications to check the COVID and the best time to check the COVID. That's all.
Yeah. So actually, I think Dr. Sanjay has spoken a lot about the testing guidelines. And I think you all are kind of already in sync and you've gone through all the versions of ICMR 1, 2, 3, 4, the latest of which gave a major focus and emphasis on the testing, the rapid antigen testing. Before that, they started with only international travels and only testing for patients who had contact, to now patients in any group, to now doing rapid antigen tests for even patients getting admitted in the hospital who require to get any surgery which could be high risk or aerosol generation, which honestly in our setup translates down to every admitted patient. And I'm sure the same thing works out for everybody else. So we go to the next question to Dr. Alpana Razdan is that the most important thing, how is sample transported and how is it stored, and what are the biosafety precautions which are to be followed, since they are the most, this is where everybody is very scared to even handle a specimen. So Dr. Alpana will tell us what is supposed to be done. Dr. Alpana?
Thank you, Dr. Poonam.
Yeah.
Can I have my slide?
Yeah.
So as far as the sample is concerned, the sample is basically a nasopharyngeal or an oropharyngeal swab, which is taken by health professionals. The swab, which is a synthetic fiber swab, which is used for taking the sample. And the major constraint for the person taking the swab is that he has to be properly protected. So the gear that he has to have is the PPE that they wear, which includes a head cover, goggles, a face shield, masks, gloves, a gown to cover, and shoe covers. So once the person is fortified with all these things, only then he can go to the COVID patient and take a swab sample. Once the swab sample is taken, it is inserted into a VTM, which is a viral transport medium, and for transport. The samples are transported via a biohazard container with using a triple packing. The triple packing is basically, it has a rigid outer packing, and then the list of contents should be properly mentioned on the package. The package has to be watertight. There has to be an absorbent packing material for liquids inside the tube, and the infectious material will be inserted onto all these packaging, and then transported into the lab. In the lab, the sample has to be handled only inside a biosafety level 2 cabinet or level 3 cabinet. The specimen samples sent to the laboratory are placed in the biosafety cabinet, and the process makes the virus non-infectious and lessens the risk of contracting the disease during processing. The biosafety level 2 cabinet
Dr. Alpana, you're not audible.
airflow is recirculated. There are HEPA filters in that biosafety cabinet, which prevent any contaminants to escape into the atmosphere. Limited access and with documentation and mandatory full body clothing is all that is required for handling of these COVID samples. The personnel who are laboratory personnel who are handling the COVID samples have to be very adept in all these things, and they have to take the precautions before handling the infectious material. Thank you.
Yeah, Dr. Alpana actually had a couple of comments and a question. It may not be the most politically correct. But what happens in our setup is that first when we started transporting sample, the NO would come wearing the entire PPE. So now we have got them to the point where they just wear a mask, gloves, and they're carrying the whole thing in ice pack. But my question to you is this, is that the WHO, CDC, everybody recommends this triple packing. What is your compromise practically?
Yes.
What do you accept practically?
I would accept something, the tube, if it has been sealed with a parafilm, because the cap is the most important ingredient. When we have seen
Yes.
the tubes crack most of the time and the VTM comes out, and sometimes we do not get any sample at all. So a
Yes.
cap, securing the cap is very important. And then it can be into a biohazardous Ziploc bag and covered with another layer of packing. That's
Yes.
what we can
Yeah.
accept.
Yeah, even we accept that. We accept it if it just the top has been sealed and it's put another Ziploc and the whole thing is in the ice box. So
Yeah.
this is the only compromise because getting the cardboard box
Yes.
has proven to be a huge challenge for us. So and I'm sure it is the same with you and with
Yes. And
everybody
when
else.
you
Hmm.
when you get so many samples and you have to uh, process around 400 to 500 samples a day, it becomes very difficult to remove each and every sample from that packaging, and that is an arduous task in itself.
I
So, and
agree.
also I wanted, yeah, and I also wanted to talk about the duration and temperature of storage. So up to
Mhm.
1 to 2 days, 1 to 2 days, it can be stored at 4 degrees in an ice cold environment. And if it is up to 5 days at -20, and if it is more than 5 days, the sample has to be stored at -70 degrees centigrade.
Yes.
That's all. Thank you.
That's very important. So thank you, Dr. Alpana. And I especially really wanted to talk about practically what happens and practically what is really acceptable and doable for all of us. So I just now go ahead to Dr. Sunita. Dr. Sunita, could you just kindly tell us what are the types of tests done in COVID? Over to you, Dr. Sunita. Yeah,
Ma'am, you
Dr.
need to unmute yourself. Please unmute yourself, ma'am.
Sorry. Okay.
Yeah.
Can you hear me, Sana?
Yeah, go ahead, Dr. Sunita.
So the first test that was introduced for COVID, incidentally, is the gold standard still. So we basically have molecular tests today, antigen tests, and for serosurveillance, we have the antibody tests. The molecular tests are used to detect genetic material of the virus. We generally use as samples secretions from nose and throat, preferably both, collected in the VTM with nasopharyngeal swabs. Now, the antigen tests have come up recently. They may be used to detect antigens which are a part of the virus. Actually, as ma'am said, there are spikes on the virus. So these antigen tests, some of them detect the spikes, the envelopes, or the membranes. So that's how the antigen tests are different. The serological blood tests are only for serosurveillance and not for diagnosis of COVID. And they are used to detect antibodies in response to the infection following the infestation with COVID. Antibodies persist for some time after the infection has passed. So it can only inform who has been infected in the past. The RT-PCR in respiratory samples is the gold standard for diagnosis. As I said, it's based on amplification of 2 and in some kits 3 target genes. Screening gene of coronavirus is the first thing, and that is usually the screening genes are E, S, N, or M. The confirmatory genes of SARS-CoV could be RD, RP, N, or the open reading frame, as ma'am said, 1 or 2. So we must have a screening gene positive and at least one confirmatory gene positive to call it a positive case. If we have only one of them positive, then probably we'll have to repeat the test. And different kits have different genes. That's how kits differ from each other. So that's about the RT-PCR. Now, apart from the RT-PCR, ma'am, can I have the previous slide, please?
Yep.
Apart from the RT-PCR, we have now come up with TrueNat and Expert Express. These are both cartridge-based tests. TrueNat is an indigenously developed RNA a kit in which you have an RNA extraction needed. Very short RNA extraction is required, and a single test also can be run. The TAT is around 2 hours. While the Expert Express from Cepheid in the form of Gene Expert, you don't require any separate extraction. The turnaround time is only 30 minutes. Of course, the cost is very high, and we use it only in cases which is really an emergency. RT-PCR is a very good test, except that we batch the tests and the TAT is around 24 hours. It's a long drawn process of extraction followed by the amplification. So if you need a report quickly, you can use a TrueNat and Cepheid Express as a backup, but the equipments are not available in all the labs. There are a few factors which affect the RT-PCR COVID tests. Of course, the foremost is the care during collection. The collection has to be done very well. Technique of transport and PPE already Ma'am Alpana has discussed. Sensitivity of the kits of the test overall is 60 to 70%. It's very, very site dependent first. Ball is 95% sensitive, but a very difficult sample to have. Sputum 70%. Nasopharyngeal is 50%. Naso and the throat swab both put together, very good sensitivity. While the only anterior nasal swab only 30%. Well, different genes are targeted by different kits, and that has a lot of impetus on the sensitivity. So by experience, we realize what are the best results received in our lab. The specificity of RT-PCR is very high. However, it does not equate with the viable virus. If somebody said how specific, does it indicate how much viable virus? No, it doesn't. A positive swab in a symptomatic patient usually will mean that she is a case, but he or she is a case. But in an asymptomatic case, a positive swab may either mean that it's a pre-symptomatic patient, you have picked up the patient in an early stage, or he's an asymptomatic carrier, or he's a post-recovery. So if you have a patient who's positive today and after 1 week, 2 weeks, 3 weeks again positive, so probably we are looking at a post-recovery patient or an asymptomatic carrier. So about rapid antigen tests which have come up now, they are very inexpensive, very fast. They are done on nasopharyngeal swabs, not on only nasal secretion tests, which very many people are doing nowadays. So please insist on a very good sample, because we're getting a lot of false negatives in antigen tests because of the poor sampling. It's a point of care test, low cost, as I said. The turnaround time is only 1 hour. It has to be done on site within an hour of collection. Naked eye evaluation of a card within 15 to 30 minutes. It's very specific. So a positive rapid antigen test immediately says it's a positive. It's almost 100% positive. A negative, if the patient is sensitive, if the patient is symptomatic and has a rapid antigen test negative, so please, you must make sure that that patient undergoes a PCR test, because probably we are missing out. The false negatives are very high. It's not a sensitive test, but a very specific test. So about the antibodies, antibody response will depend on the severity of the disease. There are cases we have seen who have had a very mild illness, or probably an asymptomatic positive case. They do not develop antibody. So that doesn't mean patient is not immune, but probably the antibody levels are so low that cannot be picked up by the commonly available kits. Then the types of antibody tests available, lateral flow assays are the card tests, which are not recommended, not even advised by the ICMR. So please go ahead and use ELISA kits or the CLIA and the eCLIA tests, very much available. So various types of antibody tests again are available, either IgG antibodies or both IgG and B.
Dr. Sunita, yeah.
So please use IgG antibody. Definitely you must use IgG antibody. Commercial kits detect binding antibodies, not neutralizing antibodies. And there is variable sensitivity and specificity of many kits. Now, surprisingly, radiology has a very good role in detecting COVID. So, CT scan is more sensitive than a chest X-ray. A CT finding is usually will be a ground glass opacity, a subpleural and lower lobe, unilateral, bilateral, not specific. But it's very much obvious when we see a case. May be present in even mildly symptomatic or asymptomatic individuals. We see many cases who come negative for COVID, but it's full-blown COVID when you see the CT scan. Immediately we know that after 3 or 4 days, we'll repeat a COVID and we'll find it positive. So we should only use it where RT-PCR is negative and patient is really symptomatic. Not available if PCR is not available to the patient, or a test report is awaited and you're in a hurry to give steroids. So it's a very fast way to pick up COVID. It should not be the first test for COVID though. So there are a few ancillary tests that we use in the laboratories. They are not for diagnosing COVID, but are usually used in all cases, whether we get COVID positive or suspected COVID patients with negative results. They assess the severity and ruling out other illnesses. In mild disease, these tests may be normal. In severe disease, you would find a lymphopenia, a raised neutrophil leukocyte lymphocyte ratio, usually a raised NL ratio.
Dr. Sunita, I can't hear you.
think Dr.
Yeah.
Sunita
Hello.
has
Yeah.
solved the condition.
I think Dr. Sunita, are you there? No. Okay, so I think that is a lot about the test. So at the end of the day, we have a lot of tests which are available to all of us. The panel is wide, and it depends upon us. And it is very much important, not only regarding the PCR, the TrueNat, the COVID, or the you doing the other test. It is also the importance of even these ancillary tests and the radiology test. I'm so glad Dr. Sunita has spoken about the chest X-ray and all, because many people are literally using an X-ray chest as the diagnosis. Before the COVID test comes, they do the X-ray chest. Okay, X-ray is coming, showing some pictures, it is there. So everything has to be used in place, and it has to be correlated actually with what it is. So think about it, and many of us probably need to educate our clinicians and tell them about which are the tests and what is actually the use of the whole lot of them. So coming to the next thing, Dr. Alpana, what are the kits used for RT-PCR and the target genes?
Yes.
Yeah.
So as Dr. Poonam and Dr. Sunita has already covered, the viral kits, the viral target genes are basically NES or F1AB and RDRP, which are based on the structure of the SARS-CoV-2 virus. Presence of these viral targets are being used for any validated RT-PCR kits to confirm a positive detection of the SARS-CoV-2 among the patients. RT-PCR, as you know, is a gold standard diagnostic test, which offers reliable, high-quality results for the early detection of these genes in human nasopharyngeal and oropharyngeal swabs. So the workflow is like this, that the sample is treated with several chemical solutions that remove substances like fats and proteins and extract only the RNA in the sample. This extracted RNA is a mix of the person's own genetic material and, if present, the viral RNA. Once the viral RNA is transcribed to DNA, the RT-PCR technique is employed, which is a highly sensitive and specific technique and can deliver reliable diagnosis in as little as 3 hours, and for which the labs usually take 6 to 8 hours. Its RT-PCR is significantly faster with lower potential for contamination, as the entire process can be carried out in a single tube. So there are kits which use either a 2-tube format or a single tube format. But as far as our experience is concerned, a single tube format is the best format, which prevents any contamination, any cross contamination. And the sensitivity of the technique is around 70% or above. And there are lots of kits that are there on the ICMR website, which have been given by different vendors. And all the kits are based on the multiplexing of either NES or ORF1AB gene. And as all has been already told by my esteemed panelists, that NES are basically screening genes, and RDRP and ORF1A are the confirmatory genes for detection of COVID. Thank you.
Yeah, Dr. Sanjeev, would you like to add in something out here on the kits?
Yeah, so while selecting a kit, there are certain criteria which should be considered, particularly the sensitivity and specificity of the kit. There are multiple kits as Dr. Alpana explained. So all these kits have a different specificity and sensitivity. So if kit is near about 100%, that seems to be the best. In addition to that, other factors which should be taken into account is the ready to use master mix. Because most of the kits which are there in market, they have a master mix, means analyst has to reconstitute the reagents to prepare a master mix. So this is prone to errors because human technicians are involved, so they can do the mistakes there. So if a kit is coming with the ready to use master mix, that is the best one to choose. And other is the target genes. At least it should have a target for one confirmatory gene and one screening gene. So these factors can be taken into account while selecting a kit. Thank you.
Yeah, I think Dr. Alpana and Dr. Sanjeev covered all the high points of PCR kits, because there are, I think, more than 90 kits which have been approved by ICMR, and it causes a lot of confusion. Yeah, Dr. Alpana.
Yes, there are more than 90 kits.
It's very much confusing.
Yeah.
And if like you, like us, you have to go on to GEM and buy it, it becomes even more crazy. If in a private sector, it was still, you at least have a choice what you're going to buy. We get crazy with the number of kits which are being supplied to us.
Yeah, but the one thing that is more important is that the quality is a major concern when you're doing this RT-PCR test. And sometimes we've seen that there are kits that are cheap, but the quality is compromised.
Yes, that is a huge thing. It's a huge thing, the quality compromising. So coming to the next thing was the question for pros and cons of TrueNAT versus CBNAT. Dr. Raman was supposed to be there, but because of some unforeseen circumstances, he could not come. So TrueNAT versus CBNAT, like it has already been said, both of them are cartridge-based tests. They both have a cartridge. TrueNAT does the test in 2 steps. It has a first you extract it in 20 minutes and run the cycle for 40 minutes. Whereas for CBNAT, it is done straight. You just have one, it's like fill it, shut it, forget it. And in 45 minutes, you have the result. The other thing, and the difference between both of them is the swab. Both of them have their own type of swab used. For TrueNAT, you have to use VLM. And the problem with VLM is that VLM is, the swab stick is very thick. So you cannot take a nasopharyngeal swab with TrueNAT. You have to take an oropharyngeal swab. It has to be a throat swab. So sometimes in hospitals like us, or those people who are having all the 3 kits, it becomes very difficult to decide which is the, it can cause a lot of confusion rather on which is the test and what is the sampling method. So the oropharyngeal versus nasopharyngeal is one issue. The second thing is that TrueNAT is in one way much more safer for us, because the collecting medium is viral lysis medium. So as soon as you put it in, viral lysis takes place and it is safe. We still require biosafety cabinet, because you never know when you open it, if the sample is leaked out or it has been contaminated on the outside of the tube, then you don't want to take a chance with your personal safety. Otherwise, technically TrueNAT was literally almost a field test. But we do it in a, we always open the sample in a biosafety thing and do the test. So TrueNAT, the sample gets decontaminated beforehand, whereas in CBNAT, it does not get contaminated beforehand. So biosafety measures have to be used as it is being used for PCR. Beyond that, in a TrueNAT, the sample can be stored at room temperature. It can come in room temperature without a refrigerator or an ice pack. Whereas for CBNAT, you require the cold stored temperature, the cold chain being maintained. So these are the 2 main differences which is there. And of course, the turnaround time for TrueNAT versus CBNAT. Would any of the panelists want to add something to it? Or I can go ahead. If somebody has some other experience to share about TrueNAT versus CBNAT.
This is Dr. Roy this side. Basically, a few things about TrueNAT is that they are very particular, saying that don't use a VTM or something. They, TrueNAT, sometimes what happens that if the viral load is very low, so this lysis buffer can also kind of denature the RNA. So if it is transported over a long time in this lysis buffer, then subsequently it may come negative while you are, if only the E gene is positive and you are going in for a RT-PCR to check the N gene or the RDRP gene. So otherwise, as a POCT module, yes, it really works very well.
It works well. And it's pretty much easy. So this is about TrueNAT versus CBNAT. If any the audience has some questions, we'll take them up later. So I would go on to the next question to Dr. Shala Malik, is that this question is, it occupies all of our minds. This test is it true? Is it false? Is it correct? Do I rely on it? What do I do? So Dr. Shalab, how is the PCR test interpreted with reference to inconclusive, false positive and false negatives?
Well, thank you, Dr. Poona. So, three types of situation are there in front of us: inconclusive, false positive, and false negative. Inconclusive, you will experience when you have not been able to detect both the target genes. So minimum requirement which is being laid down by ICMR or World Health bodies is that you have to detect minimum 2 genes. So if only one gene is detected, it is regarded as inconclusive. So why it is happening like this? The commonest reason is maybe low viral load is there, or maybe the stage at which the sample has been collected is not containing much of a viral load. So what is the line of action then? A line of action will be at lab end and at clinician end. So at lab end, generally, the process is again repeated right from the RNA extraction to the carrying out the fresh test. And again, if it comes inconclusive, the clinician has to go for the repeat sampling and the test is carried out on a fresh sample. Now, false positive is rare because the targets which have been selected are highly specific for the COVID infection. And technical error is one, as Dr. Sanjeev has already pointed out when he was discussing about the kits. So when you go for the ready to constitute kits, this is negated. Then there is another situation. If you are in a zone where already some other SARS or MERS infection is prevailing, so there is a possibility there may be cross reaction and you will get a false positive result. Then next thing is false negativity. Again, this can be divided into three components, that is pre-analytic, analytic, and post-analytic. So pre-analytic will be mainly from the sample collection point of view, where maybe the swab has not been clearly inserted in the right mid-turbinate of the nasal area, or somebody has just taken the oropharyngeal swab. As we all know, when we talk about the upper respiratory, the nasal pharyngeal swab is the best. And if you divide into the stages of infection, in the early infection, you will get a good viral load in the upper respiratory tract compared to the lower respiratory tract. And when the patient develops pneumonia, the lower respiratory tract samples like bile and sputum, they become more relevant. Of course, to add further, the role of saliva is also being investigated, and there are many research papers on that that say the saliva is a better sample as if you compare it with the nasopharyngeal or oropharyngeal swab. So right now, as per our ICMR advisory and all the scientific material available in front of us, we are mainly relying on the nasopharyngeal, and in some cases, the labs take both nasopharyngeal as well as oropharyngeal. So next thing which can go wrong will be what is the LOD of the kit you are using. What are the targets? Although they say that minimum 2 targets should be detected, but it is a good practice if you use a kit which is having 3 targets at least. And now I am seeing the kits with 4 targets are also available. So that improves the sensitivity and the false negativity also. So staging is one, sampling is one, that can cold chain is another factor that if it is not properly maintained, it will lead to false negativity. And so what to do when you experience such type of situation? So if it is false negative and it is a symptomatic case, you will have to go for resampling after a day or a two and repeat the test. And if it is asymptomatic, then nothing has to be done in that kind of scenario. So thank you. That is all from my side.
Yep. Thank you, Dr. Shalabh. I think this this slide especially will help for us, all those doing it, to figure out that whether we're correct, what needs to be done, and help us to answer questions posed to us by clinicians, which is more important. So the next questions comes to Dr. Shelly Mahajan. When and how to declare a COVID patient as COVID negative, especially in wake of the guidelines where they do not want a repeat testing done. But it's a huge concern for not only for us who have healthcare workers coming back, and even for the general public. How do you declare him negative? How does a person know that he's cured? So Dr. Shelly, over to you.
Thank you, Dr. Poonam. Good afternoon, everyone. Before talking about when to declare a patient negative, we need to understand what really a negative test result by RT-PCR mean. So when we say that a patient is negative by RT-PCR, it means that the RNA specific to SARS-CoV-2 is not detected in the sample provided. Now, to understand the clinical meaning of a negative test result, we need to understand what a negative predictive value is. It means that essentially out of the probability of getting a true negative out of all the negatives that a particular test reports. And a negative predictive value decreases as the prevalence of the disease increases in the area, which is associated with the pre-test probability. Now, pre-test probabilities, as already been mentioned, it's basically the assumption that a particular patient may be positive because of certain factors like patient history. So is the patient been in contact with a positive, confirmed positive person? Is the test being done on a pregnant lady who's in labor? Or is it, for some pre-surgical COVID test? We need to understand that. Then what are the clinical signs and symptoms of the patient? Is the patient asymptomatic or not? Then the epidemiological information, is the patient sample coming from a high risk area, from a containment zone or not? So all these factors, they together define the pre-test probability. And a negative predictive value of a test decreases with a high pre-test probability. So can I have the next slide? So talking about specifically RT-PCR for nCoV-2, we know from the limited data that we have till now that it has a very high specificity, but a moderate sensitivity, which means that if a test is positive, then it's almost certain that the patient is positive for COVID-19. While if it's negative, a sensitivity of around 70% means that there still might be, patients which are positive and are being missed by this test. There are multiple factors which are, leading to this. It includes the route of sample collection, whether it's a bowel fluid or a pharyngeal swab, as Dr. Sunita had explained, and the time of sample collection. Now, these probabilities or this sensitivity part combined with a high pretest probability, basically tells us that a negative result should not be, a single negative result should not be directly, it should not lead to some kind of interpretation directly as far as clinical decisions for the patient goes. If the patient is symptomatic, still symptomatic, and that there is just single RT-PCR test negative, self-isolation should still be followed. So keeping all these factors in mind, we say that at least 2 consecutive RT-PCR tests should come out as negative before we declare a patient with a high pretest probability as positive, because the prevalence of the disease is high in the area. So, yeah.
Yeah. So this really tells us that what exactly it is. People talk about negative a lot, but negative, what is known, what is meant, and what is interpreted is a whole lot of different ballgame altogether. So I think the pre-test probability and these are factors which many of us are not aware. Even I was not sure about all of it. But thank you so much, Doctor. So we go next from Dr. Shelley. We now go to Dr. Colonel Pralab Dev. Dr. Prabal, the question is that travel has started. The government of India started international travel. We have people wanting to come here and people wanting to go out from here. So what is the strategy if somebody is coming or we're traveling both within the country and outside the country? Dr. Prabal.
Good afternoon, all of you. So as there was unlockdown coming up, as Dr. Poonam rightly said, there was a lot of queries and a lot of apprehensions how one can make domestic travel or travel abroad and various means of traveling. So all the guidelines have been summarized and announced from periodically from 24th onwards on the website of Ministry of Health and Family Welfare. The basic tenet remains the same. That is, wear a mask, social distancing, thermal screening. So all the basic tenets remain the same. So what they say is have your Arogya Setu downloaded and checked what is the status, wear the face mask, hand washing, respiratory hygiene, social distancing, both before, on arrival, and even while traveling also. And on arrival, there will be a thermal screening at the exit point. Asymptomatics can go 14 days self-quarantine. Symptomatic, either they will be isolated and assessed at a healthcare center. If moderate to severe, admitted at COVID care centers, and mild ones can be at home and they are tested. Next slide, please. The specific state-wise quarantine regulations updated till 30th of July are again on that website of Ministry of Health and Family Welfare, as well as on the AAI website, which gives you, like in cases specifically for various states. Like in Mumbai, they say that it is if somebody has got a return ticket within 7 days, need not go into quarantine. Otherwise, if more than 7 days, either onwards journey or return back to the same place from where he's coming, has to be quarantined. Next, please. Okay, for international travel, again, they have defined, because people would be moving in, that is arrival, mostly they would be Indian nationals who are stranded outside the country. So there are certain priorities which have been given, ones who are in compelling distress, including migrant workers, laborers who have been laid off, short-term visa holders, or expiry of visa. There are certain with medical emergencies, they have been prioritized. And from India, people who are stranded in India and want to move out, for them, there's some other categories given. Either they are the seafarers or the sea crews, or ones of different countries who are in India and wants to go back. Next slide, please. So again, the orders are very, very clear, and they are very specific in the terms before planning for travel, before boarding, during travel, and on arrival. Most important thing here is a negative RT-PCR test 96 hours prior to a journey is what is seen whenever any person who is arriving to any Indian port. Next slide, please. And on arrival, again, the same tenets, thermal screening, if asymptomatics, 14 days self-quarantine, if symptomatic or specific to that port. And again, if symptomatic, then they are evaluated, assessed, and accordingly, they are taken care of. So all these guidelines periodically updated. The latest guideline is of 2nd of August, is available on the website of Ministry of Health and Family Welfare. Next slide, please. So there are very specific, country-specific criteria as well. Like not only from Hong Kong, people who are traveling from India to Hong Kong, they not only require the test result, but also a separate certificate signed by the lab stating that they were tested, and on this particular date, their departure is on this particular date, and it has to be within that 96 hours gap. And accordingly, they are given a permission to board the flight. Next slide, please. To summarize, again, before travel, during travel, after travel, and all these guidelines are very clearly mentioned, be it for flight, or for train, for seafarers, or by bus, local travel. All the basic tenets remain same: hand washing, wearing masks, social distance, and after travel, temperature, thermal screening, and assessment of the traveler. Thank you.
I think that's pretty much explained. And I would like to add one more thing. I came to know because somebody came to me, their child wants to go on the coming Sunday. So they wanted to know what are the tests and how it's to be done. So it was not just enough for them to get the test done and for me to issue them a report. They also required the letter from me in which stated that I have been authorized by ICMR to conduct the test. They even required that letter. It is not enough to just take a screenshot of the ICMR website where your lab is located. They want the actual authorization letter from the government authority also. So this is one more thing which comes up during the international travel. They require the authorization of the lab document as well.
So in that, it is, I mean, we also face similar problems, and they are not willing to accept the from the ICMR website. If we download the document, it is a specific email by which ICMR gives you that code, the specific lab code for conducting RT-PCR. That authorization email is what is required by the travelers.
Yes, that's exactly what's required. So for those who are going to come for have people coming want to travel out, please keep that in mind. You need that authorization as well. Thank you so much, Dr. Prabal.
Thank you.
So we come to the next question, which is again, which has been obsessed about, discussed about, researched about in much detail, which is what is the relevance of CT values in COVID testing? So I will just start the ball rolling before I hand it over to the panelists, is that the CT value or the cycle threshold was the value at which once it goes above the background level, it tells you the test positivity. And it is an automatic assumption that if you have a lower CT value, then it's a higher thing because you have so many viruses, they will give you in lesser number of cycles a positive report. But the inverse does not quite work in COVID. And despite clinicians, despite many people trying to correlate it, okay, fine, you have a very high CT value, a low CT value, so this is your prognosis, this is the diagnosis, this is the plan of action. ICMR recently issued guidelines in which they have clearly said that there is no correlation between the cycle threshold level and the prognosis of the disease. And we are supposed to, which as microbiologists we all know, or as virologists we all know, is that this is used only as a qualitative test, not as a quantitative test. And this has come out because there are lots of differences between, say, a kit to kit. One kit can give a different CT value, another can give you a different CT value. So there's no correlation of the CT value across the kits. There is also variability about how the sample is collected, how good was the quality of the sample, and not only how was the quality of the sample collected, but how was it then transported to your lab, whether the cold chain was maintained, the skill of the technician, whether your equipment is properly calibrated, the pipetting is perfect. And also the other one more thing, which probably one of the virologists can explain better, is that there is also no correlation of the CT value between asymptomatic, early cases and severe cases. The CT value may be the same across the spectrum or even higher in a mild infection. So because of all of this, ICMR now does not advocate using CT values as a prognosis thing. And there have been many WhatsApps which have been courtesy the WhatsApp University, despite the ICMR guidelines coming out, a new guideline which was there saying that CT values should be used. So we need to be wary of that. And I would like to open this question to any panelist who would like to add something else to it.
No, Dr. Poonam, I think you have covered the entire thing very nicely. And now that more information is available, the entire infectious process of this virus is not very straightforward. So there is issue of the cell-mediated immunity, the innate immunity, the host responses. So there are a lot of people who have started with a very mild infection, but have actually gone on to severe clinical features. And there have been people who have had very high viral loads, ostensibly by way of looking at a CT value, but have completely recovered. And many people who have had very high viral loads have not responded and produced antibodies. And some of them who have had high CT values, that means low viral load, possibly have responded very well. So the entire thing is very confusing. In case a quantitative estimation is required to be made, then the companies must come out with a quantitative or qPCR with the standards. Otherwise, this cannot, the CT values in a qualitative test cannot be actually converted into a viral load. I think you have already covered it very well. Nothing more is required to be said.
No, dear, that was good inputs, Dr. Partha. So now coming to the next question to Dr. Tina is that what are the quality checks? Because as said by a whole lot of us, quality pipetting, etc. is there. So Dr. Tina, what do you think are the more laid down quality checks which need to be kept in mind and implemented while doing COVID testing?
Yeah, thanks, Dr. Poonam. Good afternoon all. So coming to the quality checks, so quality of any kind of test is the foremost important thing. So starting for the pre-analytical, from the pre-analytical step, first and foremost important thing is the sample collection and storage, as well as the storage of reagents. Sample collection and storage has already been discussed by Dr. Alpna, so I'll not be going into the details. And coming to the analytical step, like when we are preparing the reagents for the setting up of the PCR reaction, it should be done in a PCR workstation. So basically that should be an amplicon free area so that there's no contamination from the amplicons. So it has to be a room different from that where amplification takes place. And once we set up the PCR reaction plate, it should be run immediately so that the RNA denaturation does not happen. And while we are preparing the reaction plate, separate pipettes should be used for the controls as well as and for the samples. An internal control is used in every PCR. So it basically amplifies in the same way as the target template. And it is basically a check to see that amplification has happened. And also there are no inhibitors in the sample. So most important thing is that in a negative sample, internal control amplification should always be there. While if the sample is positive, the IC may be inhibited due to the competitive inhibition. But we have to see in negative sample, the IC should be amplified. So then we are using the positive controls. So the positive control is having a known target template. So the target should amplify in the positive control. So that means that is a check that the reaction has been set up correctly. The negative control we are using, that is basically the template is not there. Every other this thing are there. So like in case of the negative control, there should not be any amplification of the target genes. Only IC should amplify. Like if there is any amplification, that means somewhere contamination has happened either of the reagents or from the sample. And so these were basically the internal quality checks. Then we can also do the external quality assurance. So as per the ICMR, now there are designated centers for every state where we have to send the known positive and the known negative samples, as well as you can also enroll into an external agency program. So the private agencies are also there who supply the samples. We have to run them and we have to deliver the test to them, and then they send the results. So now coming to the antigen, for the quality of antigen and antibody testing. Again, for the antigen testing, the sample collection has been discussed in detail. So, but the most important thing is that once the sample has been collected, it should be run immediately onto the this test strip. Otherwise, because it has stability for up to 1 hour, and there's an inbuilt control, like the control band should always come. If there's no control band and the test band is coming, that means the test is invalid and we have to repeat the test again. So we have to see that the control band should always be there. Now coming to the quality check for the antibody testing, the different methods are available like the CLIA and the ELISA. So there's always inclusion of the positive and negative controls to see that our reaction has gone correct. And if we are doing like the chemiluminescent assay on the instruments, then we have to do the calibration of the instruments also. So when is this calibration required? It should be done when your reagent lot changes with every change of the reagent lot, or in every 28 days, or when there's a QC failure, like the controls are not coming. So then also we have to do the calibration of the instrument. So this was in short about the quality checks.
So most of us, especially those people who have already been doing a PCR for a long time, are well versed with it, and they're, I think, quick on the toes to pick up anything. The graph is not rising. What is happening? A lot of quality checks are there, and it is done. But it needs to be kept in mind, especially for the upcoming people who are right now just starting their testing. What are the quality checks coming up? So I would now hand the mic to Dr. Tina Vadva and ask one very important question: is antigen testing. Arvind Kejriwal has been wanting to ramp up antigen testing. The government is saying increase it. It should be this many more. Many places are doing more antigen testing than doing PCR testing. So what does it use? When to use antigen testing, Dr. Tina?
Yeah. So this antigen testing is important, like to detect the suspected cases, or in cases of mass screening, like we can detect early. But the like advantages that we can get a test early, the results early, so that we can isolate the patients. Like if the antigen test comes out to be positive, we can consider it as a true positive, and the patients, and then no need to do the RT-PCR. So we can isolate those patients who come out to be positive on the antigen testing. But since like many false negatives can be there, so if the antigen testing is negative, so it should be followed by the RT-PCR test.
So now actually I would like to open this question to the panelists and ask an answer, because we have faced a very big problem while doing antigen testing in all hospitals. It's actually true. One department started the antigen testing, and whatever was negative, they would send it for PCR, irrespective of whether it is required, not required, because they didn't have faith on the antigen test. And gradually, after a few days, it degenerated to them not doing antigen testing, because the residents didn't want to take a sample twice. So what is your experience in other hospitals? How do you differentiate between doing the antigen testing and doing the PCR? Do you really separate and do these guidelines, or how is it done? I want the opinion from all the panelists in the hospitals.
Yeah, we had initially started for the suspected areas, like in the ICUs where we keep the suspected patients. So we had started the antigen testing restricted to those areas only. But now we are waiting for the permission. Like now at present, we are not doing the COVID testing. It was started initially, but now we are waiting for the permission. But initially when we had started, we were doing like this for the ICU patients, or where we keep the suspected patients.
Okay. Was somebody else doing something differently? Any other
See,
center?
one has to be very clear in mind when using antigen test. That, hello?
Yeah, yes. Dr. Shalabh.
So now you are doing the antigen test. If the patient is asymptomatic, then you don't have to do anything as per the algorithm. And if it is symptomatic, you have to compulsorily proceed for the RT-PCR. So no point in doubting the antigen test or not. One should appreciate the speed and the ease of doing it, which is available on site, especially in the clinical situations.
Yes. I actually agree with you, but let me tell you what practically happened. The one particular department decided to do antigen test. So after that, because of their own brainwaves or whatever reason, they sent all the samples for RT-PCR, which were antigen negative. And it so happened over a period of 1 week, out of, say, if we processed, I think it was some 100 plus samples, out of that 4 or 5 of them came to be COVID PCR positive and antigen negative. So that created an entire ruckus, a poster on a faculty group that antigen, this patient came negative on antigen positive with this thing. That crashed out a lot of our antigen testing. Practically, this is what has happened with our antigen testing. We're still doing it, and we do for the OPD patients. At least we try to do the COVID test, the antigen testing, negative report, it's given as negative, and we do not repeat it. But for many of the inpatients, especially for patients undergoing any procedure, the clinicians do want to get repeated by RT-PCR. So I don't know what is the status elsewhere, but this is a practical problem which we faced. And the other one, yeah, Dr. Partha. No, who's talking?
Yeah, hello.
Yeah, go ahead.
Okay. Now, one thing what the government should do, they should publish their result. What has happened where the antigen was negative and PCR was carried out and the person was symptomatic versus asymptomatic. So unfortunately, this data is not visible to us. Other thing we have to appreciate that if CAR test is coming positive, that means viral load is quite high and the case is infectious. And now if you repeat the PCR in the negative CAR test cases and you find that PCR is coming positive, so maybe that load is on the lower side. We are seeing the case in the later stage of the infection.
Yes.
So it should be closely calibrated with the clinical symptoms also. Otherwise, no fun in having the algorithm which these ICMR guys have designed.
Yep. I agree, Dr. Singh. Yeah.
I
So
think
this,
Dr. Shalab is right. Yes.
yeah,
I think
I also
yes.
agree with that, because we have to follow some algorithm, otherwise we're literally duplicating the test at every point of time. So this is just last one word I wanted to talk about on antigen testing is the quality check in it. Is that for all those who are doing the antigen testing, you're supposed to kind of squeeze the buffer tube for it nicely rotated a particular number of times. But the one thing which caused a lot of false negative is we realized with our experiences that the technician doing it does not let the buffer stand for 5 minutes. So the antigen does not get extracted enough and gives a false negative report. So it is important not only just to go on squeezing it those 5 times, but also to let it stand for 4-5 minutes before putting it on the rapid card and doing the test. So which is one reason for the false negative and the quality control in the antigen test.
And another drawback is that these companies are not providing us with the positive control material. So I requested these SD guys also to provide us with the positive control material, and there should be some third-party control checks also. So that will further ease it, and one should follow the very good video which they are providing. Most of these kit companies, our manpower has to be trained and washed continuously, so that the error, as you pointed out, why they are not waiting for 4 minutes or 5 minutes, that can be negated.
Yeah, I agree, Dr. Sharap. So going on to the next question to Dr. Partha Roy, antibody testing, what are the clinical implications? And now, Dr. Partha, I will just request you to share it on your screen.
Is the screen visible?
Yeah, visible.
Okay, okay. So, ladies and gentlemen, thank you, Dr. Poonam. Actually, most of the things have already been discussed. So, unlike the PCR test or the antigen test, the antibody test is a little more vague because it is not a direct confirmation of anything really. So, initially, when these tests were planned out, people realized that maybe IgA was one of the best antibodies to have detected because it is the mucosal antibody response. However, we are basically doing the IgG and IgM where you have kits which has got both IgG, IgMs or tests which have got IgG alone. So already we have discussed that there are rapid cards which are not recommended. Then there are ELISA based tests. These are very good tests, but they are little throughput is not good and it's little labor intensive. And then we have all the other automated platforms. All of them are well validated. Many of them are doing only IgG, some are doing IgG, IgM. Really doesn't matter, because what has been seen is that especially in case of COVID, IgG and IgM both almost develop simultaneously and within 10 to 14 days, which these public health people call a seroconversion. Then they talk about seroprevalence, and what they are doing now is serosurveillance. So for all of us, we know that these antibody tests are basically for serosurveillance, and we should not talk about diagnosis in these cases. So how these antibody tests are different from RT-PCR or antigen? Firstly, the sample is blood, not any other thing. Fortunately, because it happens, I mean, we are testing almost after 2 weeks and the patient has basically recovered from acute illness. So the risk to handlers is also relatively lower, except certain rare cases which we can discuss. Now, if I get a positive report, I've got a test done, I got a positive report. So what does it mean? It may mean that, okay, I was infected, but I did not come to know, or yes, I was infected, I was COVID positive, and I was expecting an antibody positive in this case. Rest, everything is in the realms of maybe. None of them are actually saying that, yes, it happens just like that. So I now may be no longer a danger to others, maybe to my colleagues, etc. Or I may not get reinfected, or maybe I can join back work, or I may donate plasma if I am found otherwise suitable. Very rarely, even with antibody positivity, if I am fairly unwell and clinician strongly suspects I could still be infected with COVID-19, And that again, the clinician has to take a call whether he has to get me tested for RT-PCR or not. However, if I get a negative report, then I would probably say that, okay, I was never infected. Second thing, which is slightly a fearsome possibility, that if I'm not positive, I may still be susceptible to infection, and I must continue to take all precautions. Third thing that is possible is I'm a non-responder, that I may have had an infection, but I just did not produce any antibodies in the frame of time that I have been tested. Quite possible. Now, this is very interesting, coming up in a big way. Did I produce antibody which has not been detected by my test? I mean, somebody is doing on S1, somebody is doing on S2, somebody is doing anti-N. So is it possible that I have not been detected by the test? Or very, very rarely that my antibodies are negative and I could be in an asymptomatic phase of an infection now. Now that is very, very rare. Okay. Now, since mostly this is done for seroprevalence, every person or an organization that are asking for seroprevalence test must ensure that what do they do with the reports that these laboratories are giving them. They must take an advice from a doctor. They must get their result analyzed. Otherwise, many of them will just file it in their cupboards and they will not see that how many people were positive for antibody, how many were actually symptomatic or asymptomatic or also positive for COVID-19. So this analysis is really required to be made to see that how things go on, right? Now, of course, because of this antibody test and all the various tests that has come, there is so many queries from patients, doctors, sales teams, lab technicians, and I have personally faced a large number of questions. I just want to showcase a few to you so that you know that what kind of tests questions are coming, basically antibody based. Now, one patient came to me, he has already been in quarantine for being COVID-19. Now, he says that he has been asymptomatic for the last 3 days. He has got no fever, feeling absolutely well. Now, he keeps on hearing in the news, in the radios, etc., that somebody should donate plasma. So he says, I want to donate plasma. What kind of antibody test I should go through? So to whom? To these people, I have told them that, look, there is a well-laid protocol in case of plasma donation in special centers. So it cannot, this report cannot be given in a normal laboratory. Basically, a person becomes eligible and he has to be PCR negative 14 days prior to the donation per se. In addition, there are many exclusion criteria. So not everybody who is PCR negative would be the right person to donate. However, in case the tests are required, in these special centers, there is something called a neutralization test is done, which looks at protective antibodies. This is a very high-end test, research-associated test. These are not offered in the normal routine laboratories where maybe we are working. Another case was quite interesting. Is a 30-year-old man. He came and he was quite kind of bragging. He said that, look, doctor, I had fever. I took paracetamol for 3 days and I am absolutely okay. I did not go to a doctor. Over the next 10 to 12 days, 3 of my family members, including my grandmother, also fell ill, but it was mild. Again, they took some paracetamol because we didn't really want to go into this quarantine thing and all these things, and they have also become okay. Now, of course, we did not do any tests because they wanted prescription from doctors and all these things, and disease was very mild. But now, after 14 to 15 days, all of us are in home fairly okay. But somebody is telling me at least you should get some tests done. So what test should I do? So to him, I have answered that yes, in today's scenario, mild symptoms can be dealt with home isolation, provided you keep a constant check on what you are doing and how you are. However, it must be remembered that during a full-fledged pandemic, COVID-19 infection positivity and possibility is fairly high, like we have seen in case of H1N1 in 2009. So that in the pandemic phase, this happens. So I told him that at least you should have got your grandmother tested because she is at a high risk for complication. Okay, but since you have not done anything and all is okay, Now you can maybe get an antibody test to confirm infection, whether you have had it or not, but then there are many ifs and buts into that. Now this came from a colleague of mine. She was COVID-19 positive, and she says that within about 4 or 5 days, her full family also became positive. That included her infant son and her in-laws and sister-in-law. Husband, who was looking after all of them, became mildly symptomatic, but when he was tested, he was found to be PCR negative. Now she says that now that quarantine phase is over, myself and the rest of the people are antibody positive, which I was expecting. However, husband continues to be antibody negative, because she says that I was expecting the husband to be positive because he has been so much in contact with all of us. Now, what she's saying, asking is that, is it possible that he has developed some different kind of antibody which we are not detecting? So there's no straightforward answer to that. I only have to tell that usually people who are COVID negative, COVID-19 positive by RT-PCR are expected to show positive antibody levels after, say, 14 days. In some case, it could be 21 days also. Now, if your husband is still antibody negative, that basically means that he did not contract the illness. Had he been antibody positive, I would have considered this RT-PCR that was done on him to be false negative. However, he may be a non-responder. He may have been positive with a very low LOD. Now, as she's asking about other antibodies, how can we check that? Now, here comes the concept of orthogonal algorithm, which is very, very important. Now, what is this orthogonal algorithm that we talk about? Now, most of the IgG antibody kits are detecting either this or they are detecting the anti-N antibodies. Now, ELISA kits are being developed and they're already going evaluation, where there are 3 different wells for anti-S1, anti-S2 and anti-N separately, and these will turn out to be confirmatory tests. Now, these are going to be important tests for vaccine efficiency studies. If you've taken a vaccine, you have to see what kind of antibodies you have actually developed. Now, similarly, it is now being strongly said that as the prevalence is going down and when it will go less than 2%, then the PPV will also go down. So that is the time you would require probably 2 PCR or 2 antibody tests simultaneously, and this will be the orthogonal algorithm to especially in the low prevalence settings. So this is what is coming up. So this is almost everything about the antibody testing. So meanwhile, I have been asked by Dr. Poonam to also speak a little on various strains that are circulating in India and what are its clinical implications. So mainly in the virology terms, we use terms like clades, variants, biovariants, etc. So I would show you 2 diagrams. So they look very complicated, but don't get worried. So what this basically says is this is called a dendrogram or a phylogenetic tree. Now, each COVID-19 virus is different from the other. It may be very small difference, but then once you do a sequencing, put it into a computer, there is a software which aligns it in a position that it should be there. And now then you see there are things like clusters and clades. This is how, now there are some like this. So as you see this round one, this and this, these are much farther apart. And as we open it up, this one and this one are the ones which are showing the maximum variations. All the blues have got very, very minimal variation and similar. So of course, in the entire world, we would like to know that what kind of strains are circulating in India. So these are about 500 strains that has been done in the world. I mean, through the sequencing process, and this is how it looks. Now, this looks very cluttered. So we wanted to see that where the Indian strains are. Are these the Indian strains, or are these the Indian strains? But to great interest, it is seen that Indian strains are also, or the clades and the variants are also distributed all over these things. So it is not that India has this very specific kind of a strain unique to India. It has got, I mean, the same strains are seen other places of the world also, and the other strains of the world are also seen in India. So when we come to the word mutations, now here you can see the mutation part of it. So basically, mostly what has happened is we have seen about 5 to 10 mutations. Now this is the area which seems to be important. That is the G clade. Now here there have been nucleotide changes, etc. So, but there has been 5 to 10 mutations in these clades. Now what is the significance of that? The common mutations that we have seen are in the spike region, or the nucleocapsid region, or the open reading frame 1 region. Now most of these are point mutations, single mutations, and these are missense mutations. That means it does not have too much of a significance in the sense that it has not changed the nature of the virus, it has not increased its virulence too much, and fortunately, unlike the influenza viruses, no major antigenic shifts or drifts have been seen in case of these coronaviruses. Now, what is the implications of these variants? Now, although clinically they may not be too much, but when we develop our diagnostic kits, if we exactly know that what are the mutations that is come up, we can target those areas and the specificity of the diagnostic tests can be improved. Similarly, for vaccine development, if you remember that the American vaccine for HIV was tested in Thailand and in America. Yeah, I'll just finish it. So in India, it could not be done because this did not include the subtype C. So once we look at these variants, we can see if there are certain shifts and drifts, and this will be very important in the post-pandemic phase to see what kind of strains have actually stabilized in India, and they will also become part of our routine diagnostic viral tests. Yeah, thank you. Thank you.
Thank you. So Dr. Partha, can you just switch the screen?
Yeah, I will do that.
Yeah, so we are almost to the end of the discussion. So I would like to ask one last question from Dr. Shelly Mahajan, which is, what is the role of pooling of samples? Dr. Shelly?
I think you have to unmute.
I think you have to unmute.
Unmute, ma'am. Yeah. Ma'am, still cannot hear you.
Can you hear me now?
Yeah.
So can I see the slides, please?
Yeah, they're there.
I can't.
Is it visible?
No.
No, ma'am. Share, please, ma'am. You have to share, ma'am.
Wait a second. Hold on. Okay. Give me 1 second. Fine. Yeah. There we go. Yeah, Dr. Shelly.
Yeah. So before going into how pooling is done and what exactly pooling is, ICMR had a few months back issued an advisory on the recommendations for pooling, and which were again based on, I'll go back to the term I used in my previous discussion of a pre-test probability. So again, here also for pooling, ICMR recommends that it should be used only in areas with low prevalence. Or it should not be done in high risk individuals. Like it should not be not really recommended in symptomatic patients or contact of a symptomatic person. It should be confined to asymptomatic individuals who are maybe coming from a low prevalence area. ICMR has in that advisory, it was they had mentioned a low prevalence area to be less than an area where the prevalence is less than 2%. While if the prevalence is 2 to 5%, then again it should only be again should be pooling should be done very conservatively, and all the asymptomatic individuals should symptomatic individuals should still be excluded. Now, the preferred number of samples. The cutoff of 5 samples has been applied by ICMR it can be anything between 2 to 5 samples. And why is that? Because more than 5 samples, there will be dilution in the pool, right? And any sample which has a low viral load may be missed. Hence there is a possibility of missing out on positives in such cases. So now I'll talk about what pooling is. Can I have the next slide? So why pooling, this whole pooling thing came into picture was that there was increasing number of cases in the city, and then it became extremely critical to increase the number of tests to, cater to the increasing number of cases. And hence the concept of pooled samples for screening came up. Now, when we pool, for example, 5 samples and the RT-PCR or the test comes out to be negative, it means that all the 5 samples are negative. We can easily, interpret that all the 5 samples are negative, provided all the ICMR recommendations were followed for selection of pooling of samples. While if the pooled samples, it turns out to be positive, then we need to do a pool deconvolution, which means that all the 5 samples or 2, 3, 4, whatever number of samples were in the pool, all those samples need to be individually tested again to see which one of those was positive. So this is a very, very simple, explanation of what pooling of samples mean and when and how it should be done. Only thing is that it is a very, very, it's a very good thing for increasing the number of testing and decreasing the cost of the test, but it has to be used in a very, very stringent way, following the recommendations. Cannot be done in patients or asymptomatic patients, even asymptomatic patients coming from a hotspot region. They may have a low viral load, and we will it's a high possibility that the cases would be missed. It can be used in a low prevalence area from where asymptomatic patients are coming for whatever indications, be it pre-surgical or pregnancy or travel purpose. So there it can be used, but again with very, very stringent protocols. Thank you, and I'll be happy if anyone else has anything to comment on this.
Well, pooling was initially started for transfusion transmitted infections, for HIV, HCV, and HBV, because they were bloodborne. In fact, even during the H1N1 scare in 2009, when pooling was coming up in a big way for the blood banks, this was not really a choice method, especially when the pandemic is on. So I think ICMR initially spoke about it, but subsequently did not talk about it. And I don't think anybody is actually really planning to do a pooling for respiratory viruses, because bloodborne viruses is different. So I don't know whether the ICMR is planning on this or not. So I don't think this would be a very good idea when the pandemic is on. Once pandemic goes over, then maybe one can think about it.
Yeah, right. So the advisory had come like 2 months back when there was a sudden rise in cases and need to ramp up the testing, I think. But I don't think it has been followed or talked about since then.
Yes. Dr. Poonam,
ma'am, please unmute yourself, ma'am. Dr. Poonam, you need to unmute. Unmute, ma'am. Unmute. You are muted.
Sorry, I'm so sorry. Yeah. So I think this brings us to the end of a lot of the questions. So we have some questions which are there in the chat box. I can see it right there. So can I just request somebody from Workha, Dr. Sanjeev or Dr. Rishi to take over the chat questions?
Yeah, so Dr. Rishi is facing some technical issues. So I will just take all the questions which are coming up from the audience one by one. So my first question, this question is from Dr. Rajesh Agrawal, and is asking how reliable is saliva testing and what are the new horizons? And the second question from him is, any COVID-19 antigen in saliva or blood can be tested? So this question, I think Dr. Prabal can answer.
Yeah, I mean, as regards saliva testing, it is a newer method where it is being thought about. There are already FDA approved kits available. From first week of May, these kits are available It is a do-it-yourself type kit. A home collection can be done, and initial studies showed that the specificity was low, about 91-92%. But there are some studies which was done at Bangkok, and it shows that specificity is to the tune of 97-98%. And that gives a lot of positivity. In the Indian context also, it is being discussed and thought about. Maybe sooner we will be seeing it. And the advantages are that for children or for people in whom collection is a big problem, okay, or in a larger case where a lot of samples need to be collected, where we have a problem in getting phlebotomists to collect them at a larger scale. So in those situations, to ramp up the testing, it would be a very good option.
Okay, anybody has to add to this? Any other panelist?
Once it is introduced in the country, I think people will work on that. Definitely, I think as Prabal is saying that the ease in collection of the sample and the amount of saliva is also much larger. So, obviously it looks like that the viral load oblique the antigen load will be much better in a saliva. But once it comes in Indian condition, people will have to do the validation.
Yes.
So
it has been tried in other virus also. Saliva test has been tried in other virus as well.
For HIV, it has started. It's been tried.
Yes. HIV, even for Zika and all, they have been tried, and there were good results. So it holds in a pandemic like this, when all the governments are trying to ramp up their testing. It would be a good option, where most of us, we face a problem about getting phlebos to ramp up the testing. So there, a home collection and collect it yourself and submit it, chance of cross-infection, wearing PPE, all those norms can be reduced considerably.
Plus it will have a cost impact also.
Yeah, certainly.
Only the collection part of it is that the saliva has to, if the saliva has to be put directly into a VTM, that may be a challenge. So that's why swabs are there. So I think once it comes, people will develop techniques to use it to the best way.
I'd like to add something to it. It's actually more of a wonder. I'm just wondering, and I have no point of reference to what I'm going to say. So when we do, for example, a buccal mucosa sequencing or a genetic sequencing on that, we find a lot of mutations because of high tobacco chewers or smokers in the country. So do you think, so any of you, would that affect the results in Indian scenario, or do you think the viral RNA, no non-specific binding amplification would happen?
No, because it is, since the virus is secreted and excreted into the place, so that it is not there for a long time, so that a local smoking or a spice or some sort of a carcinogen or something can actually modify. It can do to the mucosal genetic element, but I don't think it will do to the viral element, because it is there for a very short time. It is not exposed to a long time.
Yeah, but I would like to add on, we are doing a project on this. So we have to instruct the patients 1 hour prior to giving the sample, he should not have eaten anything. And to add on, we have found 2-3 cases where the RT-PCR was negative from the nasopharyngeal swab, but it came out to be positive from the saliva. So, and looking at the advantages of it also, I think it can prove to be a good sample. Maybe if later on.
Mouthwash and betadine, this also has to be avoided.
Yeah, so the instructions have to be explained clearly to the patient prior to giving the sample.
Okay, I quickly move on to the next question from the audience. The next question is from Dr. Tasneem Usman. This question I will request Dr. Alpana to answer. The question is, does any viral load test available for COVID? And the next question is from Dr. Naresh. What does negative antibody test mean?
So I don't know of any viral load test kits available as of now. But I think more or less they must be in the process of manufacturing, or they must be doing some validations and all on those kits. But right now we do not have any kits available.
Not only the kits, but also no threshold has been established that which levels you will call it significant and which levels will be insignificant. So both the things are there.
Actually, CDC did a limited study. So what came out was that a viral load in case of a respiratory virus, there are too many variables into it. First and foremost, you establish a viral load in which particular sample, because different samples have different viral loads. Had it been a single test like a blood test, it could have been better validated and standardized. But when we have for COVID itself, we have got nasopharyngeal swab, we have got a anterior turbinate swab, we have got BAL, and so many other this thing which have been proven to have different viral loads. So therefore, it was difficult for people to actually say, and as the viral loads many times did not, go into clinically provable complications, etc. So I think that was a major challenge in coming up with viral load-based quantitative PCR.
Okay. The next question is basically a price-related question. So I don't know anybody can answer. So this question is from Dr. Advait Banga. What is the price of TrueNAT? Yeah, Dr. Purna.
I can answer it. The price of the screening test is 1,344 rupees and the confirmatory test is 1,200 rupees.
Yeah.
But now the government has capped the testing at 2,400 rupees. And the CBNAT or that was costing 2,777 rupees per test. But all are now capped at 2,400. So I can tell you the cost.
But TrueNet people are now offering confirmatory part as free.
Yeah.
So that will take care. You can do the e-gene, and if it comes positive, run the confirmatory, which is free. So you can accommodate it in 2,400.
Yes.
And every state.
TrueNAT is also coming up with a combo chip now. They're planning to launch a combo chip which will have both of them in the same card to kind of cut down their cost on it.
Right, right.
Okay. So the next question is for Dr. Tina. This question is from Dr. Vijaya Babu. Antibodies can be persistent for how many days?
Like IgG antibodies, they usually start appearing after around 14 days of infection. But like there's no proven this thing as to now like how long they are going to persist. So we have to keep a follow-up. Like but it has been observed like even after 20 days of infection, the patients were having the antibodies. But exactly till how many days they are going to persist it's difficult to say at this point, because we'll have to analyze the complete data and then we can have a point, like we can give a fixed number of days, like till these many days they will be available in the serum.
Okay.
So best practice will be to give advisory that repeat after every 3 months will be good.
Yeah. So once we are following up the patients, then we can have an idea like how long they persist.
I also have had an experience in a few cases where even 3 weeks after declaring a patient as RT-PCR negative, the patient was positive once and then negative by RT-PCR, and then even after 3 weeks, the antibody test came out to be negative. Has anyone? It has happened in very few cases, but it has happened. So anyone of experience in that? Do you think it's related to whether the patient was asymptomatic or symptomatic, or is it just random non-responders or anything like that?
We have seen such cases.
Yeah, even we had 2 cases where they were mild symptomatic, and even on follow-up, the IgG antibodies continued to be negative only. So I think those patients who develop mild symptoms, they are not mounting the IgG antibodies. We had 2-3 cases. Our staff only.
Yeah. We also had that in our staff. Yeah, we also had in our staff a microbiologist. She and entire family had COVID positive, and none of them developed antibodies. Even the last that I knew was up to 21 days they didn't develop it. So it's there.
Yeah, and they had higher CT values also. So I don't know whether the higher CT value also correlates. Like the CT values were around 31, 32.
Yeah. Actually,
Yeah, Dr.
this is reality of this infection, that 1 to 2% will not develop antibody. And then if we have listened to Dr. Partha also, that the role of orthogonal testing. So this which type of antibody kit you are using now, there are publications that how in some scenarios the antibodies developed first to the nucleocapsid, followed by the spike, and vice versa. So all these problems are also associated with COVID.
Yes, you're right. But a very important thing that has that with the antibody testing that has to be brought into this forum is that it has now been seen that with the plasma therapy, lot of people who are getting plasma are not mounting a antibody response, because the plasma which has got antibody is killing all the antigen. So these are the people who are not they are not the one who are developing any antibodies, because that part has been suppressed. Number two, of course, this plasma itself in very few cases is also precipitating what is called a CRS, that is cytokine release storm. Now, people who have been given plasma are unlikely to have a full-blown antibody response, and even if they do, they will do it much later on. So these are the people who are the first candidates for vaccination. Secondly, these are the people who have to be kept under monitoring with their antibody responses to see as to how they are producing any antibodies or not at all. If they are not, they are the ones who are at a risk for reinfection. So this is going to become important.
Dr. Poonam wants to add to something.
Yeah, no, I don't want to add. I want to ask, how much time more do you have?
Yeah, so maybe
1 hour and 45 minutes. How many more questions can you take? Up to you.
So we can continue for next 7-8 minutes more.
Yeah, okay.
We'll move the questions. The questions will keep on pouring. So we will take some selected questions. So the next question I would like to ask Dr. Shalabh. The next question is from Dr. Naresh Kumar. Is asking how to interpret the negative and indeterminate antibody test.
See, in case of negative, two possibilities are there. Either we have tested too early, we are too early in the window period, or the second thing is the exposure to COVID has not happened. SARS-CoV-2 has not happened. That implies the negativity. And indeterminate, indeterminate has to be retested with the advisory of 1 to 2 weeks. Come again for the retesting of antibodies.
Okay, so the next question is for Dr. Sanjay. This question is from Dr. Rashmi Bari. Dr. Rashmi is asking, does the problem of persistence of post-COVID case RN exist? Dr. Sanjay.
I didn't follow what she is asking.
Does the problem of persistence of RNA exist?
The question. Hello.
I think she implies continuous shedding of virus. But then, as we all know, PCR can't differentiate between viable and non-viable. So that is also a reality. The long shedding, which is seen after 4 and 5 weeks of infection also.
A limited study that was done in China, in Wuhan. Of course, everything that is Chinese, we have to see how authentic is it. But they have come up with a study saying that the virus usually the viral RNA can usually be found positive in the body up to 20 days. And in some cases, it has been found even up to 36 days. But yes, they have not been able to really say that whether it is the tissue remnant of the RNA which has been existing in the cells. These are all autopsy findings. So after autopsy which has been done and samples which have been kept, it has been found that people who have died after 36 days in the ICU or something, up to 36 days it has been found positive RNA. Usually they found that it can persist up to 20 days inside the body. RNA.
We have had 2 cases in which I have known people with RT-PCR coming positive up to 51 days.
Okay.
And currently there's one patient who's already been there in the ward for 45 days and his PCR repeat has been coming positive. So
must publish these figures, because I knew up to 36, but yes, these are the cases which may continue to shed the virus in the community and even maybe as asymptomatic people, and continue the pandemic further. So people must know these cases.
Okay. So the next question is for Dr. Poonam. This is a very interesting question from Dr. Rajesh Agrawal is asking, how do we decide about the quality of the kit? Dr. Poonam.
Yeah. How do you decide the quality of the kit?
Yeah. How do you decide?
It is a very difficult question to answer, because there is no real way to decide it unless what we do is check one kit against the other kit and see what comes. There is no way which I can say how can you decide the quality of the kit. And the other thing which is there depends on the qualities. How many targets is the kit doing? 1 target, 2, 3, 4. How many targets are there which might give you better result? But that's all that I can say about it.
Okay.
So the other way you can do it, you can carry out a verification study where you will establish accuracy, precision, and comparison with the third-party samples. And of course, the targets and the other ease of doing, they are important. LOD is important. That will be also detrimental.
Okay. So I will take just a last couple of questions now. This question is for Dr. Shelly. Dr. Samir Gupta is asking, among CBNAT and TruNAT, which test is more sensitive and specific? Dr. Shelly.
I couldn't hear you. Amongst TruNAT and CBNAT?
Which test is more sensitive and specific?
Okay. So I think both have, as Dr. Poonam had described, both have their pros and cons. And in terms of sensitivity and specificity, I think both are highly specific. And I'm not sure about which one is less sensitive than, Dr. Poonam, would you have any inputs in that?
Actually, I really can't say which is more sensitive, specific, kind of equivocal, but there have been some cases which have been seen in which if you compare the CBNAT with PCR, the gene expert has picked up samples which have a very, very low viral load, which could not be picked up by PCR. So that is a comparison which I have, but between TruNAT and CBNAT, no, there's not too much of a difference.
Comparison, yeah.
This is a very loaded question actually, because and it's hazardous to answer such questions, because first and foremost, what is the sensitivity specificity data we have? It is from the kit insert which the company claims. Okay, so most of the companies would claim 96-98% sensitivity and 96 to 98% specificity, but now we know that most of the PCR kits are only 50 to 70% sensitive. So the best thing is to do is to go to the validation body which has given them validation. I mean, if it is the FDA, in the FDA website, each kit has, the entire thing is given, that under what LOD, what tests were performed, and at what PPV it was done, at what confidence level it was done, and then they will come out. Suppose if it is 95% sensitive, they will say it has been done 95 sensitivity when the prevalence is 5%. Okay, PPV is 88% when the prevalence is at 5. So these small little things are there. So in case we want to know about CBNAT and TruNAT, I will request the person asking the question, please go to the ICMR site, please see the validation, ask for the reports on the RTI, and actually see what they have validated. Otherwise, we have only data from the kit inserts, which we don't know how true or how false they are. Yes, our personal experiences will always matter. That's a different issue, but we cannot really comment it.
Okay. So I think I can take the last question of the day. There are many questions that are coming up in the question and answer and the chat box as well. Let me assure all the doctors who have joined us for this live webinar. We will touch base with all the panelists, the experts who are present over here, and we will definitely answer your question offline. So the last question is for Dr. Prabal. This question is from Dr. Sanjay. Is asking. There are some kits which are providing ready to use master mix. So does it make any difference? Dr. Prabal, you are on mute.
We are not using any of this RTU master mix. Anybody else who's using it? If anybody who has got a personal experience to share on this.
Okay, maybe Dr. Sanjeev Kumar can add to that.
Yeah, you see the most of the kits in market, they don't have ready to use master mix, and the technicians have to reconstitute different reagents and make the master mix. And there is a possibility of error there. So definitely a kit which is providing ready to use master mix is an advantage with respect to the speed of testing as well as avoiding the operator or analyst errors.
Okay. So thank you so much, all the panelists. We express our sincere thanks for this particular live webinar and answering all the questions that have come from all the doctors who are attending this live webinar. So thank you so much. And just to end the today's live webinar, I invite our Associate Vice President and the Business Unit Head, Mr. LCS Sri Vishnu, to give vote of thanks and the concluding remarks.
Thank you, Dr. Sanjay. Thank you, Dr. Sahu. Yeah, sorry. At the outset, I take enormous privilege in thanking the whole galaxy of microbiologists who are the experts in this field of diagnosing. And it was a wonderful session, and it was very clearly moderated, channelized by Dr. Poonam, who has done a very, very great job in terms of her moderation, and well supported by Dr. Sanjeev and Dr. Rishi Jain. And I thank Dr. Shahu for his good anchoring along with them. And I take the privilege in thanking each and every one of the panelists, Dr. Alpana, Dr. Tina, Dr. Shelley, Dr. Partha Roy, Dr. Prabal Dev sir, Dr. Sanjay Mehta, Dr. Shalab Malik, and also all the doctors who have been presented, and they have given a very, very great insight for this particular diagnosing as a part of this thing. So there are a lot of physicians who are joined, who are and the clinicians who are joined. So it would have been a wonderful session for them to learn about what are all the difficulties and challenges, and also what are the methods of this COVID, because they will be very busy in the treatment part and the diagnosing part also. Now they will be very clear. And because I got this particular forum, I would like to just emphasize what is WOCAD has given to this particular industry in last 1 month or 2 months. And in fact, WOCAD has made every one of us proud who was there in the part of Indian pharmaceutical industry, because for the second time it has happened in Indian pharmaceutical industry history that Indian company has come out with its own original molecule, which has been researched and developed in India itself. So this is a very, very big achievement, because India always look forward for a molecule from Western countries. And this time, for the second time, it has happened that we have come out with our own molecule. It has happened after 20 years of very, very big hard work, which has happened. Okay, so, and the molecule name is levonadifloxacin. It is a fluoroquinolone, and it has a very strong gram. I'm talking about skin and structure infection, and also methicillin resistant staph aureus. This is the profile of the drug. And we have launched with a trade name called MROC and MROCO. So this is just part of this thing, how big we are, and very serious about our research and science is concerned. And not only that, our seriousness goes beyond that. And I'm saying that in terms of R&D efforts, which is the actual area of pharmaceutical company. And I'm saying that a research-based pharmaceutical company. And we are the first one to come in India with a recombinant insulin in Indian market. We are the first one to come out with biosimilar glargine in Indian market. So I'm saying our technology products like Osmo layer technology, which is a very, very highly rated technology product, which is even penetrated to US market. So these are all some of the very, very big highlights of what is WOCAR's research. And of course, many of the clinicians knows about WOCAR, how serious WOCAR is about the academics. See, right away, before getting into the product of our CoviWalk, which is our product for RT-PCR kit, we have started into the science or scientific dissemination. That is the seriousness what we are looking at. And this is the first starting program, and this is not going to end. And we are going to have many such events in future for taking the science to the next level. And also the patient centricity is the next one. We are just always, our chairman and managing director always committed to give very patient-centric product in terms of either they will have a differentiation to the patients so that it is easy for the clinicians to handle this particular product. So once again, I take enormous privilege in thanking Dr. Poonam Lamba for her fantastic moderation and well supported by all the panelists. Thank you very much once again. And thank you very much, Dr. Sanjeev, once again. And thank you very much, Dr. Shahu, once again. And I would also like to thank Mr. Nitin Khanna for his very, I'm saying that very meticulous follow-up with each and every one of you in terms of this particular organizing this particular program, and well supported by Praveen Paliwal and Vishwa Gaurav, who is part of this particular panel group. Thank you very much, one and all. And the purpose of meeting is today's delegates. And I think today, like I enjoyed the meeting and this webinar, I think everyone would have enjoyed this with a very, very great, because it is a different program for them in terms of knowing about the diagnosis. Thank you very much to one and all.
Thank you.
Have a very safe.
Bye-bye.
Thanks for.
Thank you all.
Bye-bye. Bye.